over with pre-op teaching. So before I get started on this, I want you to tell me some things that were specific that you've learned about the preoperative stage.
Lab.
Visual. Yay! Labs. Okay, so you're going to know as a nurse that you're going to look at the labs because depending on the lab values of that patient may depend on
If they have the surgery.
if the surgery is continued, and what is the most one of the most important ones that you look, or several of the important ones that you look at that you may need to report to this physician prior to PT, INR, H&H.
The liver function.
Maybe that'll work. Potassium, good. And you understand why potassium has something to do with the heart. And I don't want to put somebody under anesthesia without making sure they've got good cardiac function. EKG, because if I see an EKG abnormality in the heart, then obviously I don't want to send them under. Now, you know that those labs are done, could possibly be done, 24 to 48 hours prior to? So if there was something that you didn't really like, or they didn't really like in that, something that was a sort of low, let me just throw a hemoglobin out there too. What if you had a hemoglobin about 11? That's a little, not major low, right? But it's something that could be concerning to me. So what would I want to do as a nurse?
Take it again.
Let's get another order for that. Let's just so I know exactly what that hemoglobin is prior to going in, so I'll know that he's okay, but it's also going to give me a better understanding of what? Maybe what my needs are in surgery. What will it give me a better understanding? Yeah, perfusion. Yeah, when all else fails, just holler perfusion. It should work. Okay?
We're going to have you. To give you a baseline. to start
Exactly.
with.
Say it out loud.
It'd give you a baseline to start with.
It gives me a baseline because he's okay. Sir, I need to know if I've got a baseline when he started, he went through surgery, and then as a, what kind of nurse? Post-op nurse. What's that going to give me an idea of?
Yeah.
How did he tolerate the surgery? Exactly, because if he's got a 11.5 when he goes in surgery, because they'll operate on 11.5. They won't take you if it's 8, 9, something like that. But you know right then that if it's 11.5 and then 2 days or the next day after surgery, what do you expect them to run on that patient? Another CBC, and then that's going to tell you the hemoglobin now, and you can say, okay, here it is here before surgery, here it is after surgery. Whew. Is there would you expect it to go down? You would expect it to go down, especially on what kind of patients? What kind of surgery patients? Orthopedic, exactly. Orthopedic. I know those of you that's already been to OR know that orthopedic surgery, you lose what? Lots and lots of blood. So you're going to anticipate an orthopedic surgeon or patient to see a big drop. You got to be on it. You got to be on it post-operatively, and you want to see what it is pre-op, what it is post-op, and you may be that one that calls and says, you know what, I'm really concerned. He's dropped from 11.5 to 7. Okay, and you're going to be the one calling them saying, I'm concerned. Okay, so that's big stuff in pre-op area. What do you see one of the biggest jobs as a pre-op nurse? Teaching, education. Education is awesome. What kind of things do you see the nurse doing pre-operatively that looks at safety of the patient?
Checking
checking their consent form. Now, my consent form, am I responsible for giving the information? No. What am I doing? I am
Verifying
witnessing their signature, making sure. So let's go and say that your patient has a bunch of questions.
You can try to answer them, and it gets technical when you talk about it.
And if you get to the point that you don't feel like that student or that patient has adequate information, you can't answer enough, we're going to call a surgeon, because we want to make sure that patient is educated and feels comfortable with going into surgery. Okay? What you're going to do if you go up and let's say we're going to have surgery on the left knee. We're going to make it sign. Okay, you go in and there's nothing marked. And you look at the consent form and it says operating on left knee. And you don't know. But then when you go in and talk to the patient, he said, no, it's my right knee. We're going to say, well, let's just operate on both of them, just make sure we get the right one. Okay? No, you got to clarify that at that point in time, when you see something like that. I think evening groups had a lot of stuff that, and some instructors want everything to go perfect. I don't sometimes want you to see everything go perfect in clinical. I want you to see things that make you have to troubleshoot. Okay? The biggest thing I can tell you, if you had that situation in a pre-op situation, you know that we don't know which leg this patient's got to be operated on. But at that point, you need to say, okay, time out. Everything stops. Everybody stops talking, listens, and says, okay, we got to make sure. In other words, we got to get the surgeon in here. We got to get the patient in here, or we go to the patient's room. We got to make a big discussion about what's going on before we ever take that patient back to the OR. And it may be where we're drawing like crazy on this patient's leg, just to make sure that it's in the right, we're doing the right thing. If the consent form says something different, let's say we're supposed to operate on the left leg, and the consent form says right leg. Can you just like mark out that consent form and put them? No. We don't mark out any legality papers, because when we go to court and you got your little, we used to write ERA everywhere. Don't write ERA. That's a red flag. You know, you want to say, we don't write anymore. We type everything, but we used to just write ERA on there and like, don't do that. You discard that consent form and get another one. Now, at that point, you also have to evaluate to see if that patient's had any medication. Because if that patient has had medication, first said, they are not in their right mind to sign a consent form. Okay? They cannot write a consent form if they've had any, or sign a consent form if they've had any medication. At that point, we're going to have to use a significant other, family member, or something to sign for them, and then we'll have 2 nurses witness. Okay? So you got to look at things, and I want you to see things that don't work sometimes, so you can say, okay, stop. We got to figure this out. Okay? So remember, legality is major important. Any other things that stand out for pre-op? A lot, we're doing teaching, obviously. Advocacy, isn't that a big point of pre-op?
Start the discharge planning.
Exactly. Start that discharge planning. You know, when they come in, you're going to have a little bit of time to talk to them and say, I just want to know if you, what type of resources do you have when you go home? You know, those kind of things. If they've had hip or knee, don't you think you need to start preparing that family for what the home is like? Do you have a lot of steps? Do you have a lot of rugs? I know when my father-in-law had his hip replacement, I took my mother-in-law in her great mind, took her back to the house. I said, come on, Mama, we're going to get all the rugs. So that was like something that she could, even though she didn't realize that she was doing something, to help my father, prepare the house for my father-in-law. We were doing something that we knew we had to do to get the house safe for him so he wouldn't fall. So that was like a big thing. Those are the kind of things I used to do with my mother-in-law. Y'all might think I'm crazy, but like, we're going to make a game out of this and we're going to pick up all the rugs. So make sure you talk to your patients about getting that house ready. All right, now we've taken our patient from the pre-op area. Your CRNA is the one that goes and gets your patient in the pre-op area. They're the ones that take the patient back to the room. This phase is intraoperative area. Like I said, it starts as soon as I take that patient into the operating room, and it continues until I take the patient from the operating room to the post-anesthesia or the post-op area. So when we're talking about intraoperative period of time, it's the whole time they're in the OR. Major safety. I cannot stress to you enough about safety in the intraoperative. You will hear me say that and say that and say that. Why do you think that is so important in there?
Because the client can't do it.
Right, my patient can't do anything. And just like I tell every group when they get ready to go into the OR, it's an observation thing. You need to be observing. I don't want you in there doing a lot of care. But if your patient is on that bed and they have had Versed, and the way Versed works on me, I'm out before they ever take me into the OR. So if they're laying on that bed and they have no control of their body and their arm starts to fall off, by golly, you better get out of the observation mode. And you better go over there and you better make sure that patient's safe. You better go grab an arm or grab whatever's over there because they don't have control of it, and you got to make sure that they're safe. And we'll talk about other things that are real safety oriented in just a little bit. Okie dokie pokey. Okay. Now, there are different team members, and one of the biggest things I hear the students talk about when they go in the OR setting is, I can't believe the teamwork. Teamwork is amazing. When you go in there, you're going to see all these different people, and they're going to have different jobs, just like when we're on the baseball field or the basketball court. Everybody's job on the baseball field, you got a pitcher, and he's responsible for getting that ball across the plate. That's his job. Everybody else got to help him catch the ball when they hit it. It's just like this in the OR. Everybody's got a job. Of course, we know the surgeon. He's going to be the one doing everything as far as the actual surgery part. He's responsible. He calls all the shots. You'll also see a lot of times, especially orthopedic surgeons, they bring physician assistants with them, PAs. And it's really nice to have a surgeon that has someone that he works with every day and knows exactly what he's anticipating. And I think that's another thing that students see in OR. They think, oh my gosh, that person that's, whether it's a surgical assistant or if it's a scrub nurse or whatever, they're reading the physician's or the surgeon's mind, because the surgeon goes like this and the equipment that he needs goes in his hand. So it's really nice to see a surgical assistant in a surgery that's very tedious, because they know what to anticipate. You will see some, orthopedics, one of the most common, open heart. Tyler, when you went to open heart, there was somebody the surgeon was doing the heart thing, but somebody else was doing something else at the same time. Surgery. What was she? A surgery assistant or he? She was a PA. So what was her job? Yeah. So she was actually taking the veins out of the patient's legs while the surgeon was getting ready to get the heart ready to implant that. So they work together. And it's nice to know that they have good communication skills among themselves. Why do you think that's important, to have two people working at the same time?
Yeah.
time. Time is a major importance when you go to surgery. We don't want that patient under very long. If we can get away with, not saying rush through the surgery and get them off, off the meds, but I'm saying we need to keep that patient under anesthesia at the least amount of time. And that's why they have these. Oh, I just can't figure this little thing. Anesthesiologist. Anesthesiologist is the one, he is the doctor. He is totally responsible for every patient in the OR that goes to sleep. So he may have 10 patients all at the same time that he's responsible for making sure that he gets everything, that those patients are safe and that they're getting all the medications. They totally rely on their certified registered nurse anesthetist. So the CRNA is the one that actually puts the patient to sleep. But one of the things I think that a lot, like Jade, your little man that was in there with you, you had a CRNA that was putting the patient to sleep. The anesthesiologist stood right there beside him, didn't he? Yeah. Right there while that patient was intubated. He was the one that was, once they intubated, he was listening, looking at the patient's vital signs. So he is verifying that that CRNA has done everything that they could possibly do to make sure that that patient was intubated correctly and was receiving anesthesia, started receiving anesthesia. So he's totally over everybody. So he's got a big responsibility if anything goes wrong. He has to maintain major communication with his CRNAs. The one thing that I think I see that I love so much about that in the OR as far as teamwork is that CRNA is watching that patient. And the minute something goes wrong, she has a beeper or she has a little something, phone or something, and she hits that number and that anesthetist is in there just like that. Nobody ever even knows that there's a concern. The CRNA, how many people have been seeing the CRNA and how calm they are? They don't get, because they know if they push that button, that doctor's going to be right there. And so he's good. If they see the least little thing happening, they got that doctor right there. And I think that is just amazing to me. CRNA, a lot of people want to go do this. If you want to do this, this is a major liability. Major. Although you make about $125,000 to $150,000 a year, good money. Good money. But you got to think about what the responsibility is every day that you go in there. You have to work 2 years in critical care prior to ever getting in anesthesia school. So you got to have, you can't just come out with your ADN and expect to go to anesthesia school. Okay, so you got to have 2 years of critical care. They are totally responsible for making sure that the anesthesia is given and that patient's vital signs, and we'll talk more about what all she does in just a little bit. Well, actually, it's right here. One of the biggest things that they do is they have to evaluate the type of anesthesia the patient needs. When they get there first thing in the morning and they go over to the pre-op area, they get that patient's chart. They're looking at weight. They're looking at height. They're looking at risk factors that patient, i.e., if patient has COPD, they're going to start anticipating things that have to be done for a COPD patient. They may turn, when they intubate the patient no longer has any ability to have or cardio, well, I don't want to say it like that. Let me back up. They're on a ventilator. So when they put that tube down, the machine's breathing for them and they have to make sure that they are watching that heart to see what it does as a response of that machine. Vitals. They'll put monitors on, and they are continually monitoring the patient's heart rate, vital signs, respirations, everything right there. You will also see as soon as if they have a catheter, especially, as soon as they put the catheter in, they're going to put the catheter right, like if I'm laying in the bed this way, and my patient's this way, and the CRNA's here, they're going to take that catheter bag and they're going to put it right there where that CRNA can watch it. So she's got her monitors watching the vital signs, and she's got that catheter right there. And what is she looking for? She's making sure that she's got adequate output, which is 30 milliliters a night. There she goes again, repeating things. Making sure. She's also making sure she's looking at the amount of fluids that go in. And she wants to see that there's a correlation there. Oh, Lord Jesus, where am I at now? Okay. That is one of the biggest things, and we'll talk just a little bit more about them in just a minute. All right. Oh, Lord of mercy. Who's getting drunk watching this? All right, we have talked about pre-op. We have talked about what pre-op nurses do. So I've sort of put it, your book is using holding area nurse. I've looked at some of the NECLEX books, and they're using that term as well. I don't know why. We've been a pre-op nurse forever. So I don't like that term holding area. But I wanted to make sure that you knew that holding area nurse is the same thing as the pre-op nurse. So you're going to see those terms interchanged. We've talked all about them, so I'm not going to go into what they do. Circulating nurse. This is the lady in charge, or the man in charge. The circulating nurse, and when I take you into the OR, I will tell you what the jobs of everybody is. One of the things that because intraoperative nursing is a specialty area. It is a specialty area. NECLEX is not going to test you on a lot of stuff that's in the intraoperative because it's a specialty thing. What they are going to test you on is the different jobs of people and what nurses' responsibility is if they are a circulating nurse or if they are a scrub nurse. So that's why I want you to understand what their jobs are. So when you go into the OR, you can say, okay, who's the circulating nurse? Let me watch her for a minute, or him, see what his responsibilities are. I just always say they're the person in charge because they are overseeing everything in that OR to make sure that that patient is safe. They're the ones that put the catheter in. Those are the ones that assist in making sure that my patient is positioned correctly, and we'll talk more about positioning in just a little bit. They're the ones that prep the skin because when infection comes back on a patient who's been to surgery, they're going to go straight to the circulating nurse and say, I need to look at her notes. I need to see what she did or didn't do in the OR that made sure that that patient wouldn't have gotten infection. They actually have to document how many minutes. So if you've got an abdominal surgery, they have to scrub, and I think I told you in your book, it shows you the different areas when you have different types of surgeries, how you scrub. It is not just a little rub down and go. They have to document how many minutes that they scrub that area, and they have to document what they scrubbed it with. One of the things that I always am amazed at and I pay attention to, and I didn't realize it so much until I got into the OR, but the belly button. I think we talked about that. When I think about washing the abdominal area, I do not think about that belly button. But I know how many times that I've pulled lint out of my husband's belly button. Remember shirt, and I'm thinking, ooh, I wonder if other people have that lint there. And it is important to clean.
That's what the nurse said whenever I was there. She was like, if you ever go to surgery, please clean out your belly button. She said, no, with a Q-tip. With
Wonderful. So, I mean, but you don't think about stuff like that. But that's her responsibility to make sure that, and I think the more I've been in the OR, the more when I take my baths is I'm like, going this number right here, making sure that I get it good and clean, just in case I have to go to surgery. Because this belly button's been through about 5 or 6 times of surgery, so it's a little bit rough down there. When the patient comes in, let me back up just a minute. When the patient comes in, the CRNA gets there, or brings the patient in, the circulating nurse immediately goes up to the patient, identifies herself, lets the patient know that she will be taking care of her or taking care of them while they're going through surgery. And most of the time patients have had versed ed at this time, so they're a little bit, ooh, I don't care what you do to me. But they still, and one of the biggest things that I love to see while I'm in there is they always go straight up and say, can you state your name for me? Can you tell me your birthday? Can you tell me what we're doing today? So there is another check. Even though sometimes they've had a little versed ed, they know why they're going in there. And they also say, what doctor's doing your surgery? So there are several questions asked again just to say, whoo, we need to make sure we're operating on the right thing with the right doctor and it's the right patient. So it's another check. I'll figure out how to work this thing in just a minute. Other things that's going on as a responsibility of the surgery nurse or circulating nurse is she needs to keep up with the traffic coming in and out. Orthopedic surgeries are the biggest one. Once that door shuts, you don't go in. That is one that they even put tape on the door and don't let you in. So if she's responsible for in there, she's going to make sure twice as much as nobody's coming in. She wants to make sure that everything in that room is sterile. It is her responsibility to maintain sterility. So as she's running around, she is constantly looking to make sure that the scrub nurse or the scrub tech is doing exactly what they need to do as far as maintaining sterility. So she is responsible for that as well. She actually communicates with the physician, with the with the families. So if there's a surgery that the family members are there, they'll have a beeper or they'll have something that she can call out there and say, just wanted to let you know that we just started the surgery. Everything's going okay. It should last X amount of hours. If there's any changes or anything, all you have to do is contact the receptionist there and she will contact me and I will be glad to contact you back. So it's lots of communication because most of you have been with a family member or somebody who's been in surgery, and that wait is killer on a family. Don't like to sit out there and wait. So I think that is a good part of her job to reassure that family member, those family members, that their patient's doing okay. They also call out and don't say, well, your family members lost 14 units of blood and now we're giving them 30. Not that kind of stuff that they're telling them, but if they anticipate a problem or a problem has happened, the nurse will call and say, it's looking like it's going to take it a little bit longer. She doesn't go in detail about what's going on, but I just wanted to let you know that the surgery was supposed to last 2 hours. It's probably going to take us about 2 hours and a half to 3 hours. Now, some people think, oh my gosh, that's not a big deal. Yes, it is if you're that family member that's out there waiting. And that sort of gives you the family members reassuring that they're taking care of my family member and they're concerned about me as well. So she does have a big responsibility. Scrub nurses. One of the biggest things that we're seeing more in the OR is there's not really scrub nurses. There are scrub techs. Can you think of the reason why they're using that as opposed? Very much cheaper. It's much cheaper to have a surgical tech than it is to have a surgical nurse. What's the difference in them two? Level of education, yeah, but what's the main thing that a surg tech can't do that a
Assess.
sure read my mind. You're getting good at this, read my mind. So the question was, what is the main thing that a surg tech can't do that a scrub tech can't do that a scrub nurse can? Jess said it. Did you hear it? Assess. They can. So in other words, they're sitting there and handing the instruments to the physician, and something's going on in the patient or something's not right. The nurse can actually assess the situation and communicate with the surgeon on what's happening. The surg tech cannot do that. She cannot make any assessment skills at all. She has none because she's not licensed.
She said to the nurse, can you come take a look at this?
If that person is sterile. Now, she communicates with the circulating nurses. Remember, I don't think I said this, the circulating nurse is not sterile.
Right.
Because she's running around everywhere. She's got to go get equipment and all that kind of stuff. But if she gets sterile, then she can come in. Now, if she can say, can you come look at this, and then we can do this number right here, yeah. But she's got to make sure that she doesn't cross over the barrier. But yes, she can, yeah, and the surgeon's going to be right there, and yeah, they're going to communicate. So the biggest thing that scrub tech does is hand the instruments. That's the biggest thing. But our responsibility goes a little bit more than that. We are able to actually help the surgeon. In other words, if he doesn't see that he's got a bleeder, then that nurse can say, here we go, here's the suction, here's this. We can make that judgment call in there. And the scrub tech just hands. Their main responsibility, and I think several of you that have been in the OR have seen this, is counting. And people say, what's the big deal about counting? You will see them, whether it's a scrub tech or a scrub nurse, they are counting every instrument that is on that table. Over and over, every sponge, everything, every needle. They have a list, and they're marking off. You've got 4 hemostats. You got 5 this kind of needle. You got 4 of this kind of needle. That is amazing. So they will do that at the very beginning, and they will also do it at the end of the surgery. Huh?
In and out.
Yeah, they'll start right before, making sure, because they want to make sure that everything that was on that table prior to is there after. Because we used to leave stuff in patients. And because of this enormous stress of counting, we are making sure that everything is there prior to or before it's finished. The other thing is they will never close a patient up until the count is 100%. They will not close that patient up because something is missing. I don't know if anybody's had the experience yet of anything being missing. But several of my students have observed things missing. And it is like a major, most of the time in the OR it's real calm and you just very, very smooth. When something is missing, there is a panic. They are in panic mode. They are in the trash cans. They are looking in the floors. They are counting again. They are doing everything they can possibly do, making sure that they find that instrument or needle or whatever they had that they're missing. They make sure they find it because they're not going to. And see, that pushed the patient more at risk because I'm going to have to keep them under anesthesia a whole lot longer until I find this sponge. But I would much rather find the sponge than my patient, leave it in my patient, and then them have to come back after they've got infected and all that kind of good stuff. So the count is absolutely amazing. They also communicate to the nurse and make sure that she knows exactly how much fluid they use for irrigation. Now, what I mean about using the fluid with irrigation is the scrub nurse starts with X amount of fluid that she's going to use to irrigate. Do you know what I mean when I'm talking about irrigating? Like when there's something bleeding, washing it out, exactly. So she's going to let them know, I started out with 5,000 cc's of irrigation. And then at the end, she's going to say, I've got 250 left. So as they're figuring out the I&O of the patient, they'll look in the suctioning canister. If there's 650 in here, and then she knows that she used 250 for irrigation, then she's going to subtract that. So that 250 is not going to be counted in the blood loss or the fluid loss of that patient. You follow me? Mm-hmm. Does that make sense? So that's a big responsibility of hers too. You also see specialty nurses. Those are ones that actually are specialized in going with different physicians in different types of surgery. Those of us that got to watch the breast reconstruction kind of thing, he brought his own nurse, didn't he? He brought his own scrub nurse, so he has his nurse right there with him, and she travels all around wherever he's doing surgery. She goes with him, and that is her job. And which I think that's just amazing, because to me that's reassuring, because that nurse knows exactly what that doctor wants. It's almost like a PA, but it's more of a specialty area. You will see the specialty nurses in the OR of cardiovascular. In other words, that's all they do. They're the ones that anytime there's a heart, that is their job. They generally do not go back into the regular OR because that's their specialty, and they just do hearts. So there's different things that I think that's a pretty neat job. Okay. Am I right? Mm-hmm. Okay. I'm feeling like I'm going backwards and not going. Some of this stuff is a little bit simple, but there's a reason why, and I think we've talked about some of these. There's a reason why the OR is such a controlled area, and I think you understand one of the major reasons is infection. And I'm hoping that you'll look at the different, when you go into the OR, look at the different ways that they control infection. One of the ways is keeping the rooms really cold. It's usually like 68 to 73 degrees. So those of you that are cold nature, you are allowed to wear a long sleeve white shirt, and then I will get you a jacket if you get cold in there. So know that it's going to be cold. Electrical safety is a major thing. My husband's an electrician, and every year I have to look at him and say, explain this grounding thing to me again. Because it still does not. I guess because I can't see electricity, I don't know how, I can't fathom how,
You get close enough, you see it.
Yeah, if I get close enough I can see it, but I don't mess with anything I can't see. And so I just cannot see. He said, just tell them that it's an electrical issue and just do it so the patient don't catch on fire. I was like, okay, I'll just tell them that. Because it just amazes me. And he's going, well, you know, electricity can come in here and it can go out another spot and it can do this and it can do that. I was like, I don't care. I don't care. I can't get this. So, but it is a major, major importance in the OR. It is, I mean, I've never seen a fire in the OR, but it happens, or it could happen. And I keep forgetting sometimes that the reason why that fires happen in there is because of the gases that we give the patient. So the anesthesia is given a lot of times by gas. oxygen is in there. So that can ignite. If a spark hits, then it can cause things to fire or catch on fire. So it is a major safety. One of the biggest things that they do in there to make sure that the patient is not going to be conducting electricity is they put a grounding pad on them. A bovie is what it's called. And they just stick it. They actually tear off the back of it, and it has a sticky thing, and they just place it on, and they usually place it on the patient's leg, and that helps decrease conduction of electricity, so the patient doesn't get shocked, doesn't transport that electricity through his body so it can go out another place. So it is very, very important. So that's one of the biggest things that you will see as far as electrical when you go into the OR. And preventing fire.
My person explained to me too that when she was prepping on these like bigger people, that she had to make sure that she was dry in all of her areas, like folds and stuff, because it would shock them too and burn them.
Oh, that's a good comment. I didn't even think about that. She said that her circulate nurse or whatever, when she was cleaning her patient, she made sure that every area was dry.
That's the triangle.
Yeah. So it'll make, with the fluid there, will increase their risk of having electricity go through them. Because you think about, and the way I think about this is I never put a hairdryer in water.
Right.
So, yeah. Because right now, I want to go to heaven, but I don't want to go right now. Okay?
And as soon as you have to pick them.
Yeah. You've got to make sure that they're good and dry in all the areas so they don't put them at increased risk of having some type of electrical issue. And there again, I do not think that boards is going to test you on how the electrical conduction thing works, because if it does, I have now failed. So what I want you to understand is that you know that fire and electrical safety is a major importance inside the OR. I don't want you to have to worry about how to explain it, because I can't explain it very well. Just know that that's a big issue with the OR. Oh, going backwards. All right. Of course, there's 3 different zones when you look at the layout of the surgery unit. This is one thing that State Board of Nursing wants you to understand as well. When you have these different areas, there are areas that you cannot go into unless you have proper attire. So in other words, any OR setting is always away from the main hospital. It's always in an area that you can't see family members walking up and down the hall like it is on a med-surg floor where you can see. So it's sort of isolated in an area of the hospital, so we don't see that traffic, and we don't make sure, or we don't increase people that are infected that come back there. So there's an unrestricted area, there's a semi-restricted area, and then there's a restricted area. Anytime you go into the OR area, I need you to be in scrubs. Their scrubs. I need you to have your hat on and your mask, well, not your mask, and your shoe covers. Now, a lot of students always say, well, Miss Walker, that nurse didn't have her shoe covers on. I'm like, okay. Do you know why she doesn't have her shoe covers on? She keeps those shoes in the hospital all the time. She never wears those shoes outside in the real world. So it's not that they're not following policy. They are following policy, but they keep their shoes in the locker room, in the OR setting, so it's never seen the outside world to bring in any type of infection. When you go into the restricted area, you always have to have your caps, shoe covers, and a mask. The restricted area is in the OR. So every time you go in there, hats, mask, and shoe covers. Every time you walk in the door, you foam in. And every time you walk out of the door, you foam out. Every time. We have got to decrease the chance of infection. This is pretty much common sense, and I hate to spend a lot of time on, you know good and well that you're not going to go with an open wound and work into the OR. Okay? So people that work in there, they are very, very strict on what type of, if they've got a cold, if they've got a fever, if they've got any open wounds or anything like that, you can't go into the OR. This is one rotation. If you have a cold or if you're running fever, you cannot go to. So if you're like Candy blowing snot over there, she's not, if we were going to the OR, she couldn't go. Okay, I'm sorry. I hate you're going to miss that rotation, but I cannot take a chance on you giving any patient an infection. Okay, so that is one that you cannot go to. I get tickled every time I say this, but good hygiene is important. But the other thing is I get tickled about is I tell y'all, no, you cannot go in there with jewelry on. Because that just harbors bacteria and da-da-da-da. But then my best friend who's a CRNA sits there and she's got the big dangly earrings and she's got all she's not going to go anywhere without having her jewelry matching what she's got on. So I'm like, I'm sorry, I don't understand, but they do it, but we're not. I'm not going to aid in anything that's could possibly cause, like your beautiful earrings right there, you can't go to the OR in those. Okay, you can't go to clinical anyway with jewelry like that. But be very, very careful that you don't have a lot of jewelry on. The other things that if you have any type of infection, if you're a staff member in the OR and you work there every day, there's many times that they will actually culture any type of open wound that you have so they can actually make sure you get treated. But if it comes back that there's an infection with you, then we may have to treat other people that you were in contact with. Okay, so it's very, very important. Oh, I'm going backwards again. Oh, I'm still going backwards. I think I've said this before. You're going to wear their scrubs, shoe covers. You're going to change when you get there. Mask. The other thing I wanted to tell you is you do not have to wear eye shields or anything on your eyes unless you were right there and are going to be splattered or going to be right in there. So I forget that a lot of times. So if I go in and you're like hanging over the abdominal cavity, say to me, Miss Walker, can you go get me some eye things? Or one of the nurses, we've got one scrub tech that he is absolutely amazing, and every time my students walk into the OR, they're like, go get them some eye shields. I'm like, why do I forget that all the time? Because y'all get right there and he wants to make sure that y'all are good and taken care of. Scrubbing. This is another thing that boards of nursing wants you to understand is the way that you scrub to go into the OR is a little bit different from how you wash your hands. Now, when I wash my hands at the hospital, I say my ABCs, just so I make sure that I'm washing good. When you scrub to go into a surgery, it is a scrub, not a ABC. Okay, and you need to scrub up to your elbows or a little farther. And they're scrubbing. They're taking brushes and they are actually scrubbing the skin. Especially, you will see them take and do their fingernails like this. There's also a little orange. Have you ever heard of an orange stick? And it has like a little point on the end of it. You will see them take that and do it underneath their fingernails. And fingernails is a major thing, so you will see them scrubbing and scrubbing and scrubbing, and they're just doing, just major. So you want to know that the scrub for and surgery to scrub in is much different than your ABCs. When they rinse their hands off, as soon as they rinse the soap and everything off, you will see them hold their hands like this. Just like you see on Grey's Anatomy. Okay, Grey's Anatomy, you always see them going, like this. So when they do that, so they've scrubbed at the sink outside the OR. You will also see them go in and push the door with their bottom and then go out. Because what's the first thing we want to do when we go to a door? And I think, who was standing out there? I think it was Hyacinth and Liz maybe?
That's what we were watching them today. Go over that, she's talking to us.
Right. We were standing out and watching another surgery, and the girl was over there just as scrubbing, and she went right to the door and pushed it in. But what was the good thing? She called herself, and you know what she said? Oh my gosh, I just contaminated myself. So then she came out and had the opportunity to talk to the students about that is the most important thing. It is not that you're going to, contamination is bad. What's bad is when you contaminate it and don't correct. That is the problem, because she immediately, which I was so excited that she actually recognized it and did something about it and made it right. So once they go bebopping through the door like this, someone, circulating nurse generally, is there with a sterile towel. And then they're scrubbing, they're drying their hands off. The other thing that you will see in that circulating nurse is she will assist the surgeon in gowning and gloving. So she actually will hold the, he may pick up the gown himself or herself, put his arms through it, and then there's a little tab on the gown. You will see him grab the tab, give it to the circulating nurse, and when she grabs that tab, he twirls. And when he twirls, she ties behind her back. So he's not, she whirls, and then they put the gloves on, and then he ties himself after he's got the gloves on. So she's not contaminating him.
It was a surge tech that put the glove on. He grabs the inside of the gown,
Mhm.
the surge tech puts it on, and the circulating nurse ties it from the inside, and then he grabs the
Tab.
no, not the tab, just
The string.
the string, and he gives her the tab, and she
Tab,
grabs
right.
it, and then he goes around and then just snaps off and he ties it.
Okay. Thank you.
It was such a process.
Thank you. It is a process, but remember what we're doing it for. They know they're not contaminating. When he gowns up and does all that kind of stuff, we're not contaminating him. Thank you for clarifying that, because I wasn't describing that very well. I was whirling, but I can't remember what I was supposed to be doing. Is State Board of Nursing going to ask you about gowning, and they're going to ask you about maintaining sterility as far as gowning. So don't stress out on how you're supposed to twirl when you get gowned. All right. All right. Are y'all at a point where y'all need to take a break?
Yes.
All right, so we've made it all the way into the surgery suite. We've talked about the different jobs of the things that are in there. Now, this is probably the hardest section that we're going to go through as far as the OR information, the anesthesia part. Now, you have to remember, I am not training you to be a nurse anesthetist. So you're going to be looking at the information a little bit different than what they would look at if you were a CRNA, because you're not going to be administering this medication. I just want you to be aware of it, because post-operatively, you are going to see the signs and symptoms of the medications that your patient has been administered through anesthesia. Does that make sense? So you're going to be focused more on, yeah, I know that my patient had this and this and this in anesthesia, so I need to be looking at those side effects. I have listed all the medications for you that I want you to know. Okay, and we'll get to that when we get that far. Anesthesia, negative sensation. The biggest thing that you're going to see here is I don't want my patient to hurt with anesthesia. Can you imagine how it would feel if you were feeling them cut you? So I really want to know that as far as a nurse-wise, that I am reassured that my patient's not going to hurt while they're getting in anesthesia. So it blocks a lot of the nerve impulses when they administer the anesthesia. I want my patient to be totally relaxed. I don't want them, because think about it, guys. How do you feel when you stump your toe? You immediately tense up, don't you? Or if you're getting ready to get an injection, you immediately tense up. So if you tense up, then that's going to make the whole procedure a little bit more damaging to you and a little bit more unsafe for you. So if we get them to get totally relaxed, then they won't have that tendency to tense up on us. Achieve the level of unconsciousness. Most of the time, what do we look at? Level of consciousness. Right now, we need to be looking at level of unconsciousness. Okay? Because I want them to be totally out. I don't want them to know what's going on at all. The biggest thing, wrong way. I'm still going the wrong way. All right. When the nurse anesthetist goes and evaluates the patient in the pre-op area, that is when her wheels are starting to turn. And I think we talked about this the other day, maybe it was in one of our post-ops or post-conferences, is one, and this was Amy, my friend, she was saying one of the things that is frustrating with particularly one surgeon is he is so quick on his procedures. So when she goes in and knows that, because there's several things that she looks at that bases her information on how much medication, what type of medication she's going to give this patient for their anesthesia. So she looks, okay, if this is a appendectomy, it should last X amount of hours. So when she's looking at her anesthesia, she's planning for that patient to be under, say, 2 hours. One of the surgeons that she works with so closely is very quickly, or does very quick, so he might sometimes do it in an hour, but her plan was to keep that patient under 2 hours. You see what I'm saying? Are you following me here? So with her experience, she knew that she might need to back off a little bit with some of the anesthesia because of the surgeon that she was working with. But generally, when the nurse anesthetist starts looking at the anesthesia that she's going to give, she's going to look at the type of surgery and the length of surgery, because different parts of our body with anesthesia act differently with different meds. So she's got to take into consideration. And I'll tell you, one of the most common ones, you want me to tell you now, or do you want me to wait till we get there? Wait till we get there. Okay. We'll talk about another one that's very, very important when it comes to the type of what we're working on and the area. We also look, is this an emergency or not? Because let me tell you, if it's not an emergency, I want to be very calm. The CRNA wants to be very calm, where she can talk to the patient and reassure the patient. And one of the biggest things that I hear Amy saying all the time to these patients when they're getting ready to go to sleep is, I'm going to be right here with you. And to me, as a patient, that's very reassuring to me. And she lets them know, I am here. I will be here when you go to sleep. I will watch you while you're asleep, and I will be right here when you wake up. So I just think that is just the biggest part of her job that I'm so proud of. An emergency, it might be the fact that, I'm sorry, honey, I'll be here when you get back, but I got to put you under. You know, I mean, not to that degree. You know what I'm saying? So it's not an emergency. It's a little bit easier. There's another way that they check on the anesthesia they use is how are they going to treat this patient post-operatively for pain. One of the most common things that you're seeing is the PCA pumps. If y'all had PCA pumps, then they set those up in the OR or set them up in the post-op area. In other words, they want to make sure that they have got the adequate tubing set up so the patient, because when you have a PCA, you got to have just specific type of tubing. So they go ahead and set that up. If they know that patient's going to be on a PCA, they set it up there, and they know what all they need to administer that post-op pain, for that post-op pain. Another thing that you're going to see a lot of is an epidural PCA. So if they're going to be pain management with an epidural, then they'll have to put that epidural in, and that is a form of anesthesia as well. They always reiterate how much food have you had. When is the last time you've eaten? Because if they're going to aspirate, they're going to aspirate on them, and they don't want that. Let's say it was a situation where they did eat something and the physician said, go ahead and let's eat. Go ahead and let's do the surgery, and they ate. What type of equipment do you think that CRNA is going to have readily available? Suctioning. Exactly. So, in other words, they're one that will plan for the worst scenario all the time. They always have that suctioning, but sometimes they don't always connect it good. So, connect it because the patient's been NPO. So they know if the patient has eaten, then they better go ahead and connect that suction. What other type of treatment? Y'all got it hot in here now.
Thank you.
Woo! This hot mama can't handle that. Right, y'all cuddle or something. Y'all are cold. What other type of equipment do you may see happening in the OR if the patient had something on their stomach? NG tube. Exactly. Can I go ahead and put an NG tube down? Yes, I can. And that'll help drain that stuff out the stomach, so that decreases their risk for aspiration. Exactly. Now, some of you when we go to the OR, we are putting NG tubes down when we're in there. That is, and I think I told you this before, don't ask your patient to swallow water to put this NG tube down. He is unconscious. He is not going to do it. Okay? So it's just one of those things that we're just going to be pushing. Okay? Against everything that you were taught, right? Yeah. But this is a different situation. Okay? When you are looking at the care of an NG tube and the placement of NG tube, you follow the procedure that you know in an alert patient. But in a non-alert patient, it changes. Okay? Safety issues. Their major responsibility with anesthesia is to make sure that that airway is maintained. I cannot tell you that enough. I think you've been hearing that from me since the day you walked in this room. Okay, we have different types of anesthesia. General anesthesia is the most common one when the patient is going to have major surgery. General anesthesia is what they will get. This is when the client loses every bit of his consciousness, all of his reflexes, especially gag reflex, is lost. They have no control whatsoever of that gag reflex. So if we've lost gag reflex, that's not good, is it? The good thing is we're not eating, right? So everything is lost when you put your patient under general anesthesia. There are 4 different things that happen in the brain when you give general anesthesia. One of the most common one is amnesia. Isn't it nice to know that we're not going to remember anything that happened while we were in the OR? I think that's probably one of the best ones is I don't want to remember. I don't care what you did. I don't know what you did to me, but I don't want to remember. Which is very good. And you'll hear so many patients when they come out post-operatively, they'll say you, I don't remember a thing. Good. I don't want you. If you see how we position them, if you see how we, you don't want them to know that they're in that situation. Pain medication is another thing that they are going to be looking at. So I don't want my patient to hurt. That is, I think that is the biggest thing. Every time I think about, oh my goodness, what if the anesthesia didn't work and my patient feels this? It just makes me hurt. Of course, we're going to hypnotize them. So in other words, I'm going to put them into a major sleep, deep sleep, and then I want to have everything relaxed. So once these so you can see what these medications are doing. There's a different medication that for each one of these areas. That the anesthesiologist or the nurse anesthetist doesn't sit there and say, I can give one drug to do all 4 of these things. It's called a balanced anesthesia. I don't know if I'm there yet. Am I there? No. We'll talk about that and you'll see it better, but it's a balance because I want to make sure that I look at each one of these areas and make sure that they're all touched on and that the patient is getting relief from every one of these areas. Now, when you have anesthesia, the patient goes through 4 different stages of anesthesia. There's a lot more things that happen in these 4 stages that I don't want you to worry about. It goes much deeper. If you were in anesthetist school, it would be a different story. But for our program and for get you ready to take your NCLEX, I just want you to know that there's 4 stages of this. And I want you to know as a nursing student, when you go into the OR, talk to that nurse about the different stages that the patient's going into because she can tell you exactly what's happening and where the patient is. Why is that? Well, I won't get that. Okay. One of the first thing is induction. This begins when the CRNA begins to give a medication. One of the first ones that she's going to give is Versed. Now we don't think, and Versed's given in the pre-op area, correct? Okay, so it sort of decreases our anxiety. Do you think of Versed being an anesthesia medication? Not generally. It is not given when we give it on the floor for anesthesia. I mean, for our patients, we don't give it for, we're not thinking anesthesia when we give Versed. But Versed is an anesthetic medication that's going to help relax patients. This is one of the best drugs you've ever seen when you need a patient to calm down and not worry. They don't care about a thing. They've got the glassy eyes. They're in the stretcher just going, woohoo, we're just having a heck of a time here. They don't care about a thing, which is good. Because how have they been feeling before they got to you?
Anxious.
Been very, very nervous, very, very anxious. So they need to relax a little bit before they're getting ready to go through this major ordeal. The patient will, the induction part, so may start in the pre-op area with the Versed. Then we bring the patient into the room. At that point, the things that the patient's feeling, sometimes they may feel a little dizzy, obviously drowsy, One of the most common side effects is they're saying to us as they're going to the OR suite is my mouth is dry. Now, what do we usually do when somebody says their mouth is dry? We give them something to drink. At this point in time, I can't give them anything to drink, but I can get some lip balm to put on it, and I have seen many nurse anesthetists have request in the pre-op area that they go ahead and give the patient one of those lip balm things to take into the OR with them so they can use it to put on the patient, because that is one of the side effects of this. So we want to make sure that that we can help them with the mouth. We might be able to swab out their mouth a lot, but don't dip that little swabby thing in a bunch of water. Make sure it's just a little water, and you can dab it around. And even if they have anything that's extra, they need to spit it out. Okay, because I don't want them having anything by mouth. During this induction thing, when we bring them into the OR suite, obviously we can't be quiet when we're taking them from the pre-op area into the OR, not real quiet. We can minimize it. But if you will look when you go into the OR setting, from the pre-op area as you're entering into the OR suites, there are signs that say quiet, please. Because lots of times patients get very agitated with all the lights going crazy and all the noise. It agitates them more, and then the nurse anesthetist would have to give them something else, which we don't want to have to give if we don't have to help decrease agitation. It's more important when they actually get into the OR setting. I move them from the stretcher to the bed. The induction still, since I gave them the Versed, it's still considering going on. At that point, we have got to make sure that we keep this patient safe. When I'm talking about putting belts on them, it is belts that actually hold the patient in. One of the best things that I'm seeing when you transfer in the OR setting is when they're transferring that patient over and they're putting the belts to strap them in, every nurse is telling that patient that they're not restraining them, which I think is very important, because I don't want them to feel that I'm tying them down and restraining them against their will. So every one of them I heard, we are not restraining you. We are putting these belts on because when you go to sleep, I don't want you to fall at all. And we'll talk more and more about that in just a little bit. Okay, am I the right one? Yeah. All right. Airway maintenance is important. At this part, when the induction begins, they will begin to start intubating the patient. And that will be during the induction part. During the second, and this is the most critical time that I can tell you that you have to be quiet. Once that CRNA has started the medication, and we'll talk about the different types of medication. When she started that IV-wise, you will see everything in the OR get quiet. Because this is a time that with the type of medication, I don't want my patient fighting the medication. I want the medication to start working on him or her so she can relax enough, because remember, we've got pain control. What are the 4 things I need to look for with amnesia, pain control, hypnosis, and relaxation? Those are the 4 things. If I'm not quiet during this and I'm not decreasing the stimulation, that patient's not going to react to the medication appropriately. Okay, they're going to start fighting it. What happens with that is the patients, once they give them this medication, their breathing will become more irregular. They lose all of their muscle tone, and they are not able to move any part of their body. So they are totally relying on us to take care of them. We've got them strapped in, we've got them safety. The bad thing that happens here is the vomiting and the spasms of their throat may happen.
You said decreased muscle tone, it says increase. It says increase.
Sorry, increased. Because what do I mean with increased muscle tone? They become spastic. Okay, because they're not letting the body do what it needs to do as far as relaxing. Yeah, and their mind's trying to say, you know what, I'm taking over here. And I want to move like I want to move, and I want to do what I want to do, but I don't want you to do that. Especially if, I don't know about you guys, but if anybody ties me down, I'm going to start fighting. I used to hate it when I was a kid. Me and my brother would wrestle and stuff, and he would get me down, and I would like freak out. You know, so, and that's what happens with a lot of patients, is they do freak out by being tied down and strapped down. Yeah, thank you for. The other thing that happens is they can jerk like this. So that's why it's very good to strap them down to make sure that they're not getting very, very spastic. Okay, this is the time that the patient's actually, in stage 3, that they're actually doing the operation. This is where I want to see that there is total relaxation of their muscles. They have at this point lost all reflexes. All reflexes have been lost. They are not functioning on their own. The machine's taken care of, because as we administer this medication, the vital functioning stop. The patient, if I didn't ventilate this baby or this mother or this whoever it is, the patient would die. So I have to have the airway, and I have to have the intubation tube in there, and they have to be connected to the ventilator to keep that patient alive. And when I'm talking about vital organs shutting down, I'm not just talking about lungs. I'm talking about bowel. I'm talking about bladder. I'm talking about every vital organ has shut down. And the reason why I'm coming to you and saying this right now is bowel's important and kidneys are important in the post-op area. Okay? Very important. At this point, my patient cannot hear anything. And this, once they get intubated good, then I will do the things that we need to do as far as positioning this patient. I need to make sure that they're positioned correctly according to what type of surgery they're going to have. And you can see in your book that there are different positions that the patients are in for different types of surgeries. So you need to make sure, I'm not requiring you to know every position that they have to be in, but know that during this time is when we position them in the correct place. All right, this is the one that we do not want to see. This is the danger one. So we're going to see throughout your time going into the OR, you're going to see stage 1, 2, and 3. I do not want to see stage 4. Because what happens with that is the patient could possibly go into cardiac arrest. That is why that CRNA has so much responsibility during sleep, or when she puts people to sleep, because she's got to be right on it. So if she sees signs and symptoms of the patient going bad, she can respond to it right then. You never want it to be in this danger stage. So you're gonna get through the 1, 2, and 3 good, and then we're gonna pull them out of that surgery around that anesthesia. Okay, so we've got 3 stages, or 4 stages. There's different types of administering the medication. One of the most common ones that you're gonna see is inhalation. What happens when the nurse anesthetist brings the patient into the room, you will see a little mask. And they will actually place the mask on the patient's nose and mouth and ask the patient to take deep breaths. This is the time, you know, when you see on TV where they say count backwards from 100 and they get to 99 or 98 and then they're gone. Okay, just sometimes people react to that gases, so they're going to sleep very, very quickly. So they're breathing in very, very good. They need them to breathe in very good. In other words, that's what I'm trying to say, is if they're not taking deep breaths, then it's not going to get down to the alveoli like I need it to put the patient to sleep. The most common one that you'll see is nitrous oxide. And I'm sure everybody has heard of nitrous oxide. The one thing with that is it is colorless and it's odorless and it's not irritating and it's administered very easily through the through the oxygen. So it's not like it goes into a special contraption that we have to give to the patient. All they have to do is put that little mask on and they inhale. That is equivalent. Well, first of all, how much morphine would you give a patient to feel good about it? 2. This nitrous oxide is like giving a patient about 10 milligrams of morphine. So you're going to have a little bit of an idea of what it's going to be like. What happens when your patient gets morphine 2 milligrams? Yeah, they pretty well, get slurred and they're just like, I can't function good. So it's about like giving 10 milligrams of morphine. Now these are the ones that I've given you that I want you to know the meds for inhalation. Nitrous oxide and those are a list of those. Now, mind you, they're not this is not something you're going to administer, correct? You understand that you're not giving these drugs. You just need to know that these are the types of drugs that are given. No dosages. There are some that I really want you to look at the side effects of because you're going to see those side effects in the post-op periods. I am struggling with this thing. Alright, another kind of anesthesia is through the IV. That's pretty explanatory. You know what's going on when it goes through the IV. One of the most common one, and this is in every NCLEX book, and it's not so much that you know the dosages and all that kind of stuff, is that you know, if everybody's heard about the Michael Jackson drug, right? Okay, this is it, pentothal. It looks like milk. And I told y'all how Amy does it by giving them just a little bit at a time to see how they react because it acts fast. Very, very fast. Those of you that have been in the OR and have seen them administer pentothal, how did your patient do? I mean, what they do? They were gone. Amy's even told me sometimes that you see patient within 10 seconds of seeing that this medication's working. So pentothal is one that you're going to see on board and know that the reason why I'm giving it is to put the patient under. The bad thing about this drug, and this is what really, I think, worries nurse anesthetists, is there's no antagonist that I can give the patient. That if I've given them too much, or they've given them too much, then there is a potential that there is a major depression of the cardiac and respiratory system. And there's not anything that I could give them to make it reverse. So that's why I think it's awesome the way Amy, and maybe all CRNAs do this, I don't know. But I think it's really awesome by the way that she just gives a little bit and sees how they tolerate it. And see if they really, she knows that once she's pushed it and there's no turning back. So, very scary. Kenalor is another medication that's given, and there again, they make their decision on what type of surgery they're having, how long the surgery is going to last, and several different other things that goes into consideration on what they pick. But the biggest thing they pick is the pentothal. Kenalog is used too. It does have another rapid onset, but the biggest thing that's different from this medication and the pentothal is this one doesn't have it's not seen that the respiratory depression is seen. So if a patient has already respiratory problems, i.e. a COPD, do I want to give him pentothal? No, because I know there's a chance that I'm going to depress him to where we may not get him back. So this might be a drug, ooh, how did I do that? This may be the drug that, am I doing this?
Yeah.
Yeah. Okay, I'm sorry. Because I walk back and forth. You don't laugh at me that. All right, so if I've got a drug that's, a patient's got COPD, this might be one that I would pick to give him, but I also know that if I give this drug, that patients have a tendency to have a hard time waking up with this one. And there's lots of things that may happen with this patient, I can't get them up. So it's going to take them longer to get up when I give them this drug. Ditropan, this one's short acting. This one's mostly given if patients are going to have a very short procedure. So an open heart surgery, this ain't going to work. Maybe going in and doing a exploratory on their ovaries. Something that's going to last very, very short because it happens quick, so I can put them under really quick, but I don't want it to hang around. Because pentothal, it hangs around. Kenalog, it hangs around. So this one right here, you get it, you give it, and patients are going to sleep, and I'm not sure.
Would it be for like a patient that gives like their kidney stones blasted or something like that?
Sure, yeah. Something that's the procedure's going to last, and I wish I could tell you a procedure that lasts an hour. You know, I don't know. Lumbar punctures, something that they're not going to be in. They're going to be in and out. Okay, other medication. Now, which one would the opioids work with? Pain. Because that's one of the things that anesthesia is going to do, right? It's going to work. You see them give morphine, Demerol, fentanyl. That is a drug that is more and more commonly used now in with anesthesia. It is mostly used for our epidurals, and we'll talk about that in a couple. But fentanyl is a very, very common change, and you know what we do with opioids. That helps my pain. The neuromuscular blocking agents. What do you think this one works with? Muscle relaxation. So this one is given in combination with the other medications, and the major reason, of course we want muscle relaxation to happen, but one of the major reasons they give it because it relaxes the jaw. So if who's seen people be intubated? When you stick that blade in somebody's mouth, that's uncomfortable, isn't it? And the way you got to position somebody, you got to pull it up. If I start tensing up like this, my jaw's not going to open up. So if my jaw's going to clench down, then it's going to make it harder for them to see my airway and harder for them to intubate me. So when I give them a neuromuscular blocking agent, I can get them to relax and I can maneuver that jaw any way I want to and open everything up so I can see, because that's a little tiny hole down there, isn't it? Very, very tiny hole. So I got to see all that I can see, and I got to help relax that so I can make sure that I can get in that hole and it's doing everything I need to open it up. When you're looking at intubation with somebody, what is one of the biggest things, and Holly, you need to not answer this. What is one of the biggest things that they're looking for when they intubate somebody? Their vocal cords, exactly. Because what can I do?
Damage.
Because that's a blade, guys. That is a blade that's going down into there. They push that tongue up. They've got a little light on it, and there's two. What do they look like when you look in there? There are two little white things on the side. And that hole's like this, and it's all dark. So you got to make sure that if you intubate them and put that tube down there, if you damage those vocal cords, look what Holly went through. She couldn't talk. You can paralyze your cords. That is not good. So it's very, very important that I give them something that helps relax that jaw so I can open everything up as big as I can get it for us to see what all's in there so I don't damage the vocal cords. Does that make sense? Good. These are the two drugs that are most commonly seen. Now, there again, I've narrowed them down for you. So your book gives you a lot, but there again, I don't want you, because we're not nurse anesthetists. And we were talking about different side effects a while ago. This is one of the major side effects that you're going to see in one of the anesthesia medications that you're going to probably see with every patient with these two drugs. Have you ever seen a patient wake up from surgery and they're shaking and their muscles are twitching? This is the drug that's been causing that. Once they have been put to sleep, this is the major one. What is the biggest thing that we want to tell somebody when they're shaking? What do we want to go do? Go get them a warm blanket. Now, who's that warm blanket helping? It's helping us, right? Is it going to help them? No, but it makes me feel better because I'm doing something for them. Even though we want to explain to them that this is a reaction from the medication, it's much easier to put the blanket on them and make sure that that'll help the situation as well. But we also need to explain, because when they first come out of surgery, they're not going to understand what I'm saying. Once they wake up a little bit more, I can say, all this shaking and all this twitching is probably coming from the medication, but if you're cold, I'll be glad to put this blanket on. So this is one, when Taylor, you were asking me about side effects, this is one that I really want you to understand that these are commonly seen with almost every patient with anesthesia, so you need to know this side effect. Atropine is a good drug that we can use if it gets so bad that the patient's uncomfortable, that we can give that to help reverse some of the reactions to it. Yes, it'll bring the heart rate up, but right now it's not going to be that concerning. Okay? Now, I would much rather them calm down on their muscle twitching. Now, if somebody has a heart rate of 120, 140, no, atropine would not be my choice of drug.
If someone's got like signs of, say, Parkinson's or something, could this trigger the shaking? Okay.
Oh, yeah.
Because
It'd make it a whole lot worse.
Okay.
Because that happens with them all the time, and then I've added a drug to it,
Right.
and that's going to make it a whole lot worse.
Because my grandpa, he would shake a little bit, but he had surgery and it
Got worse.
Yeah, it was
Now, did it get better after the anesthesia wore off?
Not really. It stayed like that. That's all I was wondering. Would it trigger
Yeah.
forever?
It could.
I was just curious. I don't know if that's what happened.
Yeah, I mean, I'm not absolutely sure. I thought you were just talking in the post-op period.
But this is
But I would
like
see it.
long term.
I would say that it would, I don't know that. But think about that. I'm really worried about it.
He's not.
All right.
It's been a couple years ago.
All right, what did we talk about a while ago? The balance anesthesia, right? So we know the 4 different things that we're looking for. Tell me them.
Pain control.
Hypnosis, pain control, muscle relaxation. Wonderful, wonderful, wonderful. I have given you an example of the most common combinations that what you generally see. I've even asked plenty CRNAs about this, but that's the most common. But you know that I'm not, with anesthesia, I'm not just giving one drug. I'm giving several different types of drugs that are working together so we can maintain all of these areas for our patients. Okay? Now, complications of anesthesia. This is one of the most uncommon things that you're going to see with a combination of anesthesia, but it is a very dangerous situation. Why do you, well, first of all, one of the biggest things that happen is for you to understand it's very life-threatening. And yes, it is not common. It is more common in our kids, our children, and our young adults. So you would think that we would see it more in older adults, but no. It's more and more common in our babies and our young adults. The bad thing is that the onset of this complication occurs very quickly. That is the bad thing. It is called malignant hyperthermia. Now, when you hear hyperthermia, what are you thinking? So you would think that maybe the first thing that happens is the temp's going to start elevating, right? Mm-hmm. Wrong. That is a late sign. That's why it's so important that that CRNA is sitting right there with that patient while she's asleep and watching that monitor. Because the first sign that you see, I went the wrong way. All right, help me out, guys. All right. The first sign that you see is the increase in end-tidal carbon dioxide. So you want to know why that CRNA is sitting right there beside there watching that machine? Because immediately when she sees that elevate, a red flag's going and she's going to start looking for this. What's happening is there is an increase in our calcium level. And you know, we have talked about potassium till we're blue in the face, right? Mm-hmm. Well, this is when it is vital to know what was that potassium level prior to me going in. Okay? 3.5 to 5.5. You go at them. So what happens with it involving the muscles is the muscles start increasing or releasing the calcium levels. Once they start releasing it into the blood, who's coming with it? Because they're partners, they like each other. Here goes calcium, and then here goes potassium. What happens with an elevated potassium? Heart starts doing what? Start going crazy. Is it pumping like it needs to? It could actually be dysrhythmia. Mm-hmm. Now, can the CRNA know what the dysrhythmia is? Yes. Can we know what the dysrhythmia is? Not yet. Not yet. But that CRNA will know that that dysrhythmia is getting ready to happen. And what do you think she's getting ready to draw? A potassium level. Yes, she is. Can you do that? Yes, she can. So she knows. Now, first of all, what are you thinking when the CO2 starts going up? Acidosis. So you've got to immediately, anytime you see CO2 going up, you think acidosis, and then you start thinking what happens with acidosis. At this point in time, I don't care if it, I want you to start doing metabolic and respiratory, but we know we're going acidotic right now, right? Because we got that CO2 going up. All right, so what I said just a minute ago, the unexpected rise. Now, when I say unexpected rise, I mean it just like within normal range, and then it goes out the wazoo, just like that. So that CO2 level, that patient is hanging on to CO2, and then when I hang on to CO2, what happens with O2?
It goes down.
It goes down. So if it goes down, they're going to be, there's a chance if the O2 count is going down, they're not what?
Perfusion.
Come on, guys. They're not perfusing. Say it like you know what's happening. So they're not perfusing, so I'm in trouble, right? So what happens is, what do you think if they're not perfusing? What do you think those signs and symptoms are going to be seen of that patient vital sign-wise?
Well,
He's going to get what? He's going to get tacky. What kind of levels am I looking at when I say tacky?
140.
Yeah, 120 to 140. I don't mean 99. I mean we're going tacky here. So the patient's going to become very rigid. What's going to happen to their blood pressure? I'm going to bottom it down. Exactly. What's going to happen with their breathing pattern? They're going to be very restless because they're what? Hypoxic. Right. They're going to be very, very cyanotic. Respiration's going to be high. Just give me an idea. What do you think they're going?
30.
Yeah, about 28, 30. Very, very. Then, you know, a while ago when we talked about the CRNA, always pulls that catheter right there. She's going to start seeing the output, and it's going to look like cola. It's going to look like cola. And then we're in trouble. Then one of the last signs as we see is, look at this temp, guys. That's not a typo. The patient's temperature goes up and can go up as high as 111. What is happening with the patient's temperature that high? It's frying things, literally. Right? This is a scary, scary complication of anesthesia. Scary, scary. But you know that you're first going to look at the unexpected rise in the CO2, the entitled CO2, and you know that a rise in the temperature is going to be a late sign.
So at what point do they actually administer a medication to stop it?
When they start seeing the end-tidal rate, the increase in end-tidal, then they look and see if they're getting tacky, and then they end up seeing if they're starting to get their respiration, and then they administer it. And you know the drug you're going to give? Narcan. Not Narcan with this. Dantrolene. Dantrolene is a med. That is a medication that is in every OR. It is readily available. I have seen some CRNAs with every case that they do. They have that dantrolene right there. So they will not have to go fidgeting and worry about getting it out of the Pyxis, because you know the best thing to do is to plan for the worst scenario so you don't have to worry about finding it. But this is the medication that you will give to help reverse this. Patients who have had it before, it would be nice that if we knew that. I wish they'd tell us, because they are at risk for having it again. Okay, doesn't mean they're never going to be able to have surgery, but can you imagine what they may be going through if they've had malignant hyperthermia and they have to go through surgery again? They would be a little bit scary. A little bit scary. All right, overdose is another thing that we look at. Why is it, I've preached to you and preached to you and preached to you about looking at medications and looking at their height and weight. The nurse needs to, or the nurse anesthetist needs to do her calculations based on this so the patient doesn't overload or overdose it. What is other things that would help me as I'm calculating my drug? What other factors am I taking into consideration? I'm taking liver function, kidney function, age. Exactly. So we have got to, I know that they have done their calculations and got it good, but there are some people that once they go into the stress of having surgery, even though I've checked the BUN, I've checked the creatinine, I've checked the ALT, I've checked the ALT, everything looked good prior to going in, once they get in there, there might be something that happens that makes them start hanging on to the meds. So we've got to make sure that we're up on this, and we know if we don't catch it soon, then the patient could pass away. Unrecognized hypoventilation. Tell me about ventilation when we go in and we intubate somebody. What's the biggest thing that we want to make sure when we intubate? It's in the right spot, exactly. Because if I don't put it in the right spot, I'm going to be ventilating. Just think about the one Jade listened to the other day. That tube was in the right side of the lung. If that nurse anesthetist would have started ventilating that patient while that tube was in the right side of the lung, would my patient have been ventilated correctly?
No.
And what can happen?
The lungs can block. Too much through the left lung.
So, too much CO2, but is he perfusing? Because he's only getting one side of that lung, right? So he's not getting adequate O2 everywhere he needs. And eventually, if they would have continued to ventilate that patient could have died. Because there was not adequate ventilation, and then he's going to start hanging on to CO2, and then he's not going to breathe. And then he's going to arrest. So just the little things like listening to breath sounds, don't you think it's important? So, you better put those stethoscopes on those chests. Intubation. We talked just a little bit about things that can happen when they intubate patients. Obviously, our vocal cord trauma is a big problem, but you can also break teeth. That's why you will see the CRNA looking in the mouth very good prior to her to make sure that all teeth are intact and make sure that there's none that are broken before she gets in there, so she'll know what she's looking at. And there can be a lot of problems with throat irritation, and they can also have a lot of swollen lips area. Now, after when you have a patient who is post-operatively, I think we talked about this the other day when we were doing pre-op stuff, their throat's going to hurt. Okay? So you need to find some interventions to help with them. You can also ask the physician to order chloroseptic spray. That is one thing that you can have to help spray, because it is, especially if it's a difficult intubation, it is very, very agitating and irritating for that patient. The other thing is it's very traumatic. It can cause swelling. And of course, we don't want swelling, because if we have swelling going on, then what's that going to do to my airway? It's going to close my airway. Exactly. All right, do y'all need a break or no?
Do you need a break, or do you need
Huh?
a break?
I do. All right, so there's other types of anesthesia. We talked about general. General can be inhaled, or it can also be given IV. But there's another one, local. And what this does is the patient, first of all, the main thing you think about as a nurse when a patient's getting local anesthesia is they don't lose their gag reflex. So I'm not really concerned so much about an airway in this situation because a local anesthesia only focuses on one area. So they're actually giving the medication to an area that they want to decrease the sensation there. I.e., when a mom is getting ready to deliver vaginal and they need to cut an episiotomy, they give a local anesthesia in that area, let it work a little bit, and then make the incision. Another example is when they have stitches. When your little boy cuts his arm wide open and needs stitches, then they give local anesthesia. The thing, there's not many people that have reactions to local anesthesia, but there are. But there are that some do, but it's very, very rare. So I don't know that I've ever, in the 25 years of nursing, seen anybody react to any type of local anesthesia, which says a lot because we can use that very, very frequently. The patients do not lose consciousness, and they are easily able to follow directions, unlike general anesthesia. There is a topical. The most common one that you will see is called EMLA, E-M-L-A. And what that work is they actually take the cream and they rub it on the area that they want to be anesthetized. Most commonly used for babies that have, or children that have to have an IV. We can put that EMLA cream on them. The bad thing is it has to stay there for about 30 minutes. So if you know that your patient's going to have, your child's going to have a IV, then you know that you can get that type of cream ordered, but go ahead and get that done one of the first things so you can do other things, and you'll need that IV very quickly, so you have to wait that 30 minutes. It used to be an hour, but they've increased it, so it's about 30 minutes that you have to wait. That is the most common one. The other thing is there's a spray that patients, that you can use if they're having difficulty in intubation, but you're not needing to have, not really all the way intubated. In other words, if you're going to have an EGD, you know what EGD is? It's where they actually do the scope, endoscopy, where they actually do the scope down through your throat into your stomach, and it goes all the way down to the duodenum. They can localize it by spraying your throat so that so you're not feeling this as that tube goes down into your throat. It is a form of intubation, but they don't call it intubation like that. But that spray is amazing. So you'll see a topical used as an ointment or a spray. I just talked about sutures. I am struggling with this dad blasted thing. They need to get me this other one fixed. It's giving me a headache. Is it giving y'all a headache? Not giving me.
Right there, top.
One more question.
Am I not there?
No, regional.
Okay.
Regional.
One more
You
question.
put the topical on, and you have 30 minutes to get it in, or you wait 30 minutes then you do it?
You wait 30 minutes because it takes 30
Okay.
minutes for the topical ointment to actually get into the skin and anesthetize that area. Then you can take it off, wash the cream off of your patient. Then you can do everything you need to do to start the IV. Now, I don't do that for injections. That is that's not one that, the IVs on children, yes. Yes, very, very common to do that. Pray you hit the vein. Yeah, but see, the thing is, you don't get it in there, don't get it in there, you're gonna have to do another 30 minutes and put it somewhere else.
Does that like blanch the skin?
Does it what the skin?
Like blanch it? Like,
A little bit, and it makes it a little bit more difficult. The vessels have a tendency to hide deep after you put that, so it makes it a little bit more difficult to stick. So, yeah. You also can, there's some hospitals that make you give them local where you're going to start an IV prior to actually starting an IV, which that's 2 sticks. That's 2 things going into my patient at one time. An IV hurts, but it's not that painful. So, plus when you put a local anesthesia over where you're going to start an IV, the vessels have a tendency to hide as well. All right. Yeah, we pray that we stick. All right, the next one is regional anesthesia. This is a type of local, and you have to remember that this one as well maintains the gag reflex. Okay, so a local anesthesia, regional type, they maintain the gag reflex. These are the ones that you see that have the epidurals for post-op pain. What other common patients do you see with epidurals?
Women in labor.
Women in labor. You know, those kind of people, as soon as I'm 38 weeks, put the epidural catheter in. So I don't want to have to deliver without having the epidural catheter in. So that's one. Field block is one that you will see. This is actually, it sort of does what it's named. When you do a local, you've got a small area that you're looking at. But we may also have a large area that I think it's a big field that I need to, it's not just a little tiny IV stick that I'm going to stick right here. It's a big area. So I might have to inject local anesthesia in a big area. So it makes a big old field as opposed to a little tiny field, and it makes it, they're not using that as much. The most common one that you see is for plastic surgery. You will see that for it, and maybe even when you have moles removed, they're not going to just give you one injection. They're going to give you all injections all the way around it to make sure that every bit. I know I always show y'all in personal thing, but I had a basal cell cancer removed from my face, and that's how he did it. He made a field about this big with several injections and numbed every bit of that. So I didn't feel anything. I had a hole in my face about this big. So just for him to get everything. So he had a bigger area. It wasn't just a little tiny mole that he was moving. Well, it was a little tiny mole, but the problem was the bad cells went deep, so he had to keep cutting. But anyway, so it's a little bit different. It's the same type of anesthesia, but you look at the different types of areas that you're working on, you may need some. I've also seen physicians actually inject local anesthesia medication into patients' areas that after they had surgery, it was it sort of helped numb that area for a long period of time. You will also see this with mastectomies and breast reconstruction. They actually put the anesthesia in like a little ball, and then they put the tube, and I'm doing my breast because that's the way I had mine. But I had a little ball here, and then they had tubes, and each tube went into both of my breasts, and it, with the suction of it, ended up doing local anesthesia so I wouldn't hurt.
They have those
In the
joint
actual,
count.
huh?
They have those on joint count.
Exactly. Joint count's another one, and it's amazing where it just sticks. But it only, I mean, I don't have to worry about my patient's airway. I know that I can still get them up and moving after post-operatively. But the lidocaine or the cane drugs or local anesthesia goes in there, and it actually numbs the site of where the pain would be. So it's a really, really neat. It's called something ball.
Q pump.
On cue pump.
They also call it an 8-ball, because it was made.
That's what I was trying to think about. What ball?
An 8-ball.
8-ball?
Yeah, an 8-ball. It looks like an 8-ball. They're in like black.
I mean, there's like different hospitals.
But then there's
ones
the
that
8-ball.
do something ball.
Drug.
Thank y'all for
Yeah. Oh, yeah, correct. Yeah, he on.
Nerve block.
Have a different name.
Nerve block is the next one, guys, that you're going to see. And this actually impairs the sensory and motor function of a patient. It is given to decrease the sensation of pain. The most common one is your, gosh, what am I doing? Where am I at? Okay. These are the ones like the epidurals that go in, the spinals, to relieve the pain after surgery. These are cane drugs. The Fivocaine is one of the most common ones that you're going to see with any types of local anesthesia. They don't have a lot of side effects, but seizures is one of the biggest things that you'll see. So you may actually see some respiratory depression, but the side effects are very, very minimal with these cane drugs. Spinal. Now, okay, this actually, a spinal anesthesia actually goes into the spinal column. The medication is going into the spinal column. So there is an increased risk of paralysis. Also, there is an increased risk of headaches. So when a patient has a spinal, they have to lay flat for 6 to 8 hours after that spinal injection. The other thing that we don't want to happen is once they inject the medication into the spinal, we don't want the medication to go up. So here's the spinal cord that they go into. You want the medication because the medication is going to be designed for you to have pain relieved right here. But there are some times that medicine will go up. And if that medicine goes up, the patient's going to have a headache. And I don't mean, oh, my head hurts. I mean a severe headache. Severe. Where the lights, you have to dim the lights, no stimulation. Worse than a migraine headache. It's very, very, very bad. So that's one. So we have to be very careful with how we take care of a patient post-operatively with spinal and not get them up. Because as soon as I get them up, that medication can go up. So they need to lay completely flat after they've had the spinal. Lord Jesus, I keep moving this darn thing. Oh, I'm going the wrong way again. Epidural. This is it is in the same area, but it does not go into the spinal column. Paralysis with a spinal is very common. An epidural, it is not as common. Okay, it does not. That is if the physician goes in the right place. Okay, there are some times that physicians go a little bit deeper and that epidural then becomes a spinal.
Not
Okay.
it's like for a lifetime later, or
I don't know lifetime unless, and I'll go ahead and say this, one of the common things that happen, you can still have a headache with epidural, but what they do with it is called to help the headache, is they do a blood patch. Have you ever heard of a blood patch? Okay, where when they go actually take the needle and the needle goes into the spine and my patient has a headache, they ended up taking blood from the patient, putting the blood in a syringe, putting the catheter into the patient's back again, putting the blood in so it fills up the hole that the needle had made, and it makes it clot up. So and that, you wouldn't believe, the patients are in excruciating pain. They do this blood patch and their headache is immediately gone away. So it's really, really neat. The bad thing about an epidural and the placement of an epidural is you've got to get that patient still. Now, I don't know if those of you who've been in labor, when you've been in labor, it's hard to be still when you're hurting. So you've got to really help them in the positioning. They need to be like a mad cat. So what happens is that epidural, that spinal is spread out. So the epidural space is opening better for them to get the angiocath in there. Now, they do not leave a needle in their back. Okay? And the needle that they use to get in is like this long, about this big around. So we definitely don't want the patient to see that when we're doing that. So make sure they get that needle, and then they take the needle out, just like you do with the angiocath when you're starting an IV. You don't leave that needle in, and you take it out. And then and it's really good when you after you have your baby, after you have abdominal surgery, after you've had any type of GYN surgery, that you can have that epidural in there. Like I told you, I had an epidural with my hysterectomy, and that's how my pain was controlled, through my epidural after I had it. With the epidural, you want people to be numb between here. Y'all see? See where you need to be numb? How many people's had a baby and their toes are numb? Don't need your toes numb for epidural. It's very, it's the only place we need to be numb. The thing of it is the patient, the physician, they're giving you too much, because you need your feet. So if you've got a patient who has an epidural and they're numb to their toes, what kind of things do you need to make sure that you do in caring for them?
False precaution.
False precaution. You are not giving them, letting them get up until what? They have every bit of their sensation in their feet and in their legs.
Is that why they catheterize? Like, that's the only time I've ever been catheterized, when I had my babies. But is it because you can't feel, or would it be just if the legs were numb, or with any epidural you're going to get?
Any epidural, what happens? If we're numb like we're supposed to be, what's right here? My bladder. If I can't feel the urge to pee-pee, then I'm not going to think about it. So what is the responsibility of a nurse that's taking care of someone who has an epidural, male or female? You bet not. We're not going to Catherine's yet. What is your assessment? You better check for
Sensational reflexes there.
What do you check for if they've got, what is it called? B-L-A-D, exactly, bladder distension. How do you check for bladder distension? You cuff it. They don't know they got to pee. Don't go stick a catheter in them. That's more invasive. You've got to see, first of all, when the last time they peed. Then you check for, check for distension. Then you bladder scan them. Then you catheterize them. So you better be, when you got a patient who's got an epidural, you better be making sure, because they don't have the urge to go pee-pee. Okay, they do not. So you're not getting them up until you've actually pinched their toes. And I mean, you got to pinch a little bit, or take an alcohol swab and rub it up their legs and say, does this feel cold? And I'm not getting. Now, another thing is you got to remember is you don't get them up and bebop them down the hall. You dangle, right? And then let them stand up for a little bit, and then, and see, that point you'll know if that medicine's going up or if it's good. and it's staying where it needs to stay. Okay, so you've got to check those things on patients who have epidurals. All right, what's going to happen when you see somebody restless or excited or incoherent speech or headache, blurred vision, metallic taste, nausea, vomiting, tremors, seizures, increase in vital signs? What are you going to do when a patient starts having these problems?
This is with epidural.
No, don't any of them. Any anesthesia medication, because you're not going to be administering these. You're going to be seeing this patient happen postoperatively. So those are things that you're going to see when I need to be concerned if a patient is having a problem with anesthesia. Any type of anesthesia. With epidurals, the metallic taste is more common. But it's also important if they have respiratory issues, right? Because if it has respiratory issues, what's going on?
Airway.
Perfusion. All right, if I've got an epidural or a spinal, and I start having increased respirations, and my patient's going, where's that medicine doing? Medicine's going up. So there's all different things that you can start looking for with every type, not just general, with every type of anesthesia. So what are we going to do? Make sure the airway's open. We're going to give O2. We're notifying the physician. We can give a fast-acting barbiturate. If we don't act fast, we are going to lose this patient. So I want you to understand that this is a very serious type of medication that has been administered to your patient, and you have got to be on it. When any patient has any type of anesthesia, you have got to be on it and knowing what you're looking for. Another anesthesia is moderate sedation. Those are used with like endoscopies. They're able to maintain their airway. I'm not going to go into detail about that. That's pretty explanatory. All right, they're usually DC'd. Okay, I'm going backwards. Okay, so let's do a quick assessment of what's going to be going on in intraoperative again. Okay? I need to identify my patient. I need to validate the consent form. Validate the side of which the surgery is going to be done. Check all allergies. Check and make sure that the blood's on site. Make sure the patient has the appropriate attire on. No panties if they're operating on their bottoms. Medical record is reviewed again. And we talked about the DNR orders the other day. They should be suspended. So you can see that many checks are done. So nothing is missed. Now, I will tell you is in the intraoperative, after all this has been done, they've checked everything. They have what they call a time out. And I failed to tell my first two groups about this time out. So when the nurses done all this checking, right before the surgery starts, they say time out. And when you hear that verbiage, stop what you're doing and stand there and listen. And what they do is they say this patient's name, what's going on with the patient, what type of surgery, who's doing it. They also ask the nurse anesthetist if the antibiotic has been on call to OR, has been given. So they go through all this stuff, and everybody that's a part of the surgical team has to agree. If there's any question about anything, it is stopped then and it will be resolved. So you make sure, so I can tell you, and I feel reassured that as what I'm seeing in the hospital setting where I'm at, is checks are done, and checks are done, and checks are done, and checks are done. So it's really, really good to actually see it happening. Now, there's several areas that are really, really concerning as a intraoperative nurse. And one of the biggest things is I need to make sure that I don't prevent injury happening to my patient. And I've told you about strapping them down and positioning them correctly, but I'm not sure if I've told you the importance of padding the areas. Have we talked about padding of the areas? I know I've talked with my group in the OR, but you're going to see how they pad everything in the OR so the patient, or the bony prominences. Have I talked about this or no? I can't remember. You will see them actually it's amazing. I get tickled every time I go in there, and they've got a different shape of how that egg crate thing is cut out. Depending on, they've seen had some patient that they needed a funky plate thing of egg crate, so it was padding, and they'd cut it out, and it fits perfect with some part of the patient's body. So they do not want, once they get them tied down and get them strapped down, if they know they're going to be in that position for a long period of time, they put extra padding everywhere on all the bony prominences. So look for that when you go into the OR. Skin is another thing that we want to make sure we've talked about, keeping that incision free of bacteria. So we've talked about what we do prior to cleaning it, or prior to them having surgery, cleaning it very well. We want to make sure that the patient's sutures are okay, and they close everything, and they make sure there's no bleeding while they're getting ready to be discharged into the post-op. All right, I'm struggling here. From an injury. This is what our goal is, or our evaluations are, when we have a patient who has been in the OR. We want to make sure that they've received the anesthesia appropriately and without any complications. They're injury-free, skin's not contaminated, and there's no tears. All right, so we have made it through intra-op. What kind of questions do you need to ask me about intra-op?
Does everyone who is going to be in surgery get catheterized?
No, depending on they're trying to get away from doing that. And depending on how long the surgery is, depending on where they're operating on, and just there's all kinds of because they're trying to decrease the amount of putting catheters in, because that increases patients' risk of infection. Plus, but you also have to realize if I don't and the patient voids, then it's contaminated everything, and now I'm going to have to clean everything up and tear down and clean and all that kind of good stuff. So yeah, it's sort of like I would rather put a catheter in everybody so they don't void and get it everywhere. But I wish, we didn't get to put in any catheters last week, I don't think. All right, so our patient has gone to post-op. And like I said, I know y'all are all going, I wish she's never going to get through all these. I wish y'all quit focusing on those darn purple. But anyway, we've talked about a lot of this stuff. Now, post-op, after our patient has been through the surgery, the CRNA wakes them up in the recovery, tries to wake them up in the recovery room, in the operating room, tries to extubate them in the recovery room. They want them extubated before they actually take them in there to the recovery room. There are also portable airways that you can, I guess it's portable, I don't know if that's a good word or not, but portable airways that you can put in or have on you in case the patient's had trouble getting extubated and you need to open up that airway very quickly. and we have already extubated them, you can go ahead and put it in, and it maintains that airway without them being hooked up to a machine and out there. If y'all ever seen an intubation tube, it's long. I mean, it's a long skinny thing, and it goes all the way down here. So you want to get that out, and then you still can maintain the airway by putting just a portable airway in there for them. But by the time they go to post-op, we want to make sure that they are extubated. The post-op area is just a big old room, and it has different cubicles. You have to remember privacy is a very important thing with post-op. But a lot of times you'll go in there and you'll see that it's just wide open, and patients are just in an area and wide open. But you've got to remember that patients are such at risk for complications of not breathing. It's better for the nurses to be able to see what's going on. Now, if you've got to do anything with your patient, then you can pull the blinds and show privacy that way. But I want to make sure that I can see everything that's going on in case one of my patients having trouble breathing. The biggest thing with the nurses that work in the immediate post-anesthesia care unit is they have to be trained in all types of emergency situation. They have to be trained in pediatrics because they're going to be having pediatric patients. They have to be trained in people that are older. So they have to have a lot of knowledge when it comes to developmental. They also have to have a lot of knowledge about all the anesthesia medications that they've just been given. So they need to know that when the CRNA comes in there and says, I gave them this, and this, that nurse has to know those medications, so if something happens, they're respiratory distress or whatever, she knows what meds they've had and what meds have antidotes and which don't. So there's a lot of knowledge. She's got to be able to think quickly. As far as what you're seeing in the post-op area, vital signs are going to be done very frequently. And they need to be documented very frequently. I just gave you a scenario of what you usually see. I'm not sure if you have ever seen orders that look like this, because that would be what the physician orders. Q15 times 4. Do you know what that means? So for 1 hour, you're going to be doing 4 sets of vital signs, right? For the next, what is Q 30 minutes times 4? So that'll be 2 hours that you've got to set. I want you to understand what that means, because they have to be documented according to that policy and according to what the vital signs are ordered by the physician. Most of the time, the physician, they will not transport the patient to a regular med-surg unit until they've made it through at least 2 hours in post-op. Okay, so most of these have been done and documented before. Of course, respiratory is our importance. They have a criteria sheet that they use to make sure that the patient has met every one of those criteria, just like if they were in an outpatient surgery. Remember all the things we talked about? You had to check off those off. Well, post-op is the same way. They got to make sure that everything is met before they're ready to be taken out of the post-anesthesia care unit and taken to the regular floor. Can't tell you enough about respiratory system. Y'all get tired of me saying this. When you're looking at, I want you to start realizing, yes, you're looking at respirations and the rate of it, but in a post-op situation, there could be different reasons why this patient is exhibiting signs and symptoms of their vital signs. Respirations less than 10, you can bet that that's probably going to be an anesthesia problem, which is a medication problem. So is that going to be easily corrected? There are medications that I can, because I know there's antidotes out there that I can give to help reverse it. But if it starts getting to where the respirations are rapid and shallow, you have not acted fast enough and you are now having cardiac involvement. Okay? So I need you to understand the importance of checking those respirations, because if it's a respiratory issue from anesthesia, I can correct it. If I don't see it at first, I'm going to have cardiac involvement, and then my patient's going to have more problems and may end up having to go to ICU as opposed to a regular care unit, because I didn't pick up that this was an anesthesia problem or a medication problem. But my students would never not see something. Right? We would always check what's going on. Listen, now I should have actually put the breath sound thing up with the intraop, and I put seen more in intraop, but I thought it was pretty, I don't know why I put it here. But I think we've talked about that ET tube being too far or not far enough, and what happens with it. The other thing I want you to realize is when you looked at that patient who has been intubated, make sure you're looking at the rise and fall together. And I think we talked about that together, because you may see this. Okay, you may see this right side going up and the left side not. Okay. All right, dang it. I'm really going backwards. I don't like this thing. Since I taught respiratory, I know what you mean. Y'all know what use of accessory muscles and retractions. And you know what snoring, and you know what stridor is. But stridor is, stridor's never good. And we talked about that in respiratory system. But once you see a patient, and most of the time when you hear stridor, a patient's dying. But once they came, and it may be just the death process that's happening, but patients who come out of surgery, it may not be a you're hearing stridor, but it may not be because they're dying. It means that they've just been intubated, and there's probably a lot of swelling going on there. So don't think that they're dying, which they might if you don't go over there and help them. Okay, so it's not always, but it's probably coming from them being intubated as opposed to them actually going through the death process. Cardiovascular. You know you're going to see a decrease in BP if you start having cardiovascular. Pulse pressure. Do you guys know what pulse pressure is? Right, the difference in systolic and diastolic. So what you do is you take the diastolic number and the systolic number and the diastolic number, and you subtract. And you get a number. How do I know if I'm concerned about that? Greater than 40. If it's greater than 40, what is that telling me? There could be something cardiac involved, so that will be another assessment for you when you're doing post-op, for you to assess if you've got rapid and shallow breathing. That would indicate a cardiac issue. So then you better be looking at that pulse pressure, because that's going to give you more assessment if there's a cardiac issue going on. Does that make sense? So that's going to give you more evidence. And if you don't start addressing that, then your patient can eventually have a cardiac arrest. But the most common one that you see is patients are going to go into CHF. And they're going to have a fluid volume deficit. And your patients will probably, the major cause of the difference in the pulse pressure and the rapid and shallow breathing is coming from a hemorrhage, which is vital for you to hit that assessment of those things because your patient just come out of surgery, and maybe they didn't get everything reattached, and maybe he's bleeding inside internally, and those are going to be the signs and symptoms that you as a post-op nurse are going to pick up that might have to mean that your patient's got to go back to surgery. Okay, got to be on it. Well, I just said that. Okay, sorry. Okay, wrong one. Oh shoot, fire. Y'all, I don't like this thing. Okay, post-operatively again, we're going to be assessing our peripheral pulses, and you've got to make sure, especially if you've had an orthopedic patient, you better be checking those pulses on both sides. I mean, no matter what, you should be doing that. The other sign that you will see, does everybody know what a Holman sign is? Okay. You are not immediately going to assess a Holman sign in the patients in the post-op recovery room. This will be later after they get out of surgery up to another unit. That's when you're going to be doing Holman. You know that you tell them to pull their toe back, and if they're hurting in the back, then it could be a possible DVT. I think I told you this at another point in time in my life with you, is when patients have got a positive Holman sign, and it's been documented, they don't want you to keep doing it over and over and over again. Do you see what I'm saying? Mm-hmm. Because if it's positive, they are then going to go in and do a scan to see if he has a DVT. Well, that's a sign that he has a DVT. So if I know he has it, quit doing it. Okay? Because as I'm doing this, let's think, okay, there's 3 different times the patient's assessed during the day. Really. I mean, should be 3 different shifts. If I'm having them do that 3 different times, what am I going to do? I'm going to remove that clot, and then I'll throw it, and he's going to have a pulmonary embolism, and he's going to die. Okay, so once it's documented good, please don't keep having them do it over and over again. Okay, neurological. One of the biggest things that you can do with neurological is you might have to look at their baseline pre-op, okay, to see how they reacted earlier. But you want to see if they're responding to commands. Epidural, we talked about that. Your motor and sensory, that's when it's so important when you've got an epidural or a spinal to look at the movement of extremities. You know what MOE is? Movement of extremities. That is more vital. Do not get them up if they can't move their extremities. Fluid overload. I think I talk about fluid overload or deficit problems. I've got to make sure that I and O are equal. How do I assess hydration? Skin turgor. Come on, skin turgor. Mucous membranes. What is a good way you can ask somebody if they are assess if they're hydrated?
Having a stick in the tongue out, see if it's moist.
Or have them make spit. Just say, can you make any spit? If somebody's really dehydrated, they can't make it. Okay, they can't make their self, and I know you're all sitting there going, all right, can I make it? What'd you say?
Slap in the face if they cry.
So I've got to make sure, now guys, they're going to be, they will have gotten lots and lots of fluid in the OR. You need to make sure that you know how much fluid they got, because you need to be catching up or making sure that their I&O is going to be equal. Okay? You also need to know, I should have clicked it back again. You also, am I going the wrong way? I am struggling. You also have to know about drainage. Will you do me a favor? Will you go on my desk and look and bring that HEMA back? Drainage is also considered a part of your I&O. So do not forget that. You've got to make sure that you keep up with that. I swear I'm going to scream. Fluids. These are the most common ones that you're going to see. Normal saline, lactated ringers, D5LR. D5LR is always given to my diabetic patients. Why are y'all not disagreeing with me? Come on, believe. Thank you, baby. Believe in what you know. Do I give D5 to a diabetic patient? No, I do not. Please do not give D5 to a patient. Come on, guys. You know that stuff. I know you know that stuff. All right. The other thing is you're going to have the change in the fluid dosage or rate will change from the time he comes out from the intra-op to the post-op, and the physician will actually write an order of how fast he wants that fluid hanging when he gets up on the post-op floor. Okay? Acid base, renal. Let me talk about renal for a minute. If I have a patient who has an epidural, that's wonderful because I can keep up with making sure that he's got urine output more than 30 an hour, right? But what's going to happen is once I take that catheter out, when am I going to be concerned? 6 to 8 hours. So I'm going to give my patient 6 to 8 hours for them to void after I have taken that catheter out. Have you heard that before? Yeah. Okay, so you know that the sphincter gets very, very lazy very quickly. So I want to make sure that I'm going to give them 6 to 8 hours. I've also put check for bladder distension with epidural and spinal. You've got to know that. Report less than How many times is she going to say that? All right, GI. This is one thing that sort of gets people concerned a little bit. And sometimes I get concerned too. You know, nausea and vomiting is one of the worst side effects that a patient can have after they've had surgery. They do it all the time, and bless their hearts, I wish there was something I could just wiggle my nose and they wouldn't have any nausea and vomiting because they've had abdominal surgery and now they're going to have to throw up. So, said droperidol and Zofran are the most common ones. But one of the biggest things that you need to make sure that you're assessing when a patient has had general anesthesia is you've got to make sure that their bowels are going to start working again. You do not want to ever feed anybody that's had surgery unless their bowels are...
He's louder than you. I don't know who that is.
He's louder than me?
Yeah.
I still can't concentrate. Okay, your bowel sounds are very, very lazy. And so when we get ready to have or when a patient's had surgery, no matter if it's abdominal or not, their bowels sometimes take up to 24 hours for them to start regenerating. So if I have a patient who has abdominal surgery and he's 24 hours post-op, am I going to be really, really concerned? Am I going to freak out?
No.
No, I'm not going to freak out. What am I going to start doing?
Fluids.
Fluids, movement.
What? Assessing, right? I'm listening, and they're not there.
Get them up.
Get them up.
Get them up. Get them up. Get them moving. So how can I help them realize that it's getting ready, that something's getting ready to happen? Exactly. This is one time in your life that I tell my post-op patients it's okay to poot. I want you to poot really, really bad. So whatever we got to do to help you poot, we're going to do it. We're going to get them up. We're going to walk them around. We're going to see. We're going to make sure that they know that they need to poot. So make sure that they need that their bowels are going to start working. Talk a little bit about NG tubes. I think you've already had that. NG tubes. The types of NG tubes. Just gave you an example of what the most common ones and why you use which ones. That is also included in your intake and output. Drainage, you know what drainage we're worried about?
Red, brown.
Red, yeah.
What am I really, really worried about when I'm talking about NG?
Never mind.
Coffee ground.
Coffee ground, old blood.
Yes, not good. If the drainage from the NG tube is coffee ground, it is not good. It is from an old bleed, so we are missing something. The patient is bleeding somewhere and we're missing it. Okay, so it means it's been there for a long time, and why didn't I get in that assessment that he's bleeding and I missed it? So, not ever a good thing when it comes to coffee ground. I think you've already had that up. All right. When you have a patient who has an NG tube, you're going to check for placement, right? Every time. Wounds, you know, some people think that they always say, you know, well, how long is this going to take for me to get this thing to heal up? Tell them to be patient. Sometimes it takes up to 2 years to get everything healed up. Okay? So tell them to be patient. I'd like to see healing taking place about 2 weeks, but it's going to take a long time for our patients to get all of their skin up for complete healing. You know what you need to assess for when it comes to integumentary, Rita, right? Drainage, you know how the changes, you've already had wounds, so you know what wounds do. The crustiness, you know about that. All right, 2 of the most, and am I almost done?
Yeah.
Okay. Yeah! All right. 2 of the most important things that can happen with a patient who has abdominal surgery, a complication, is called dehiscing or a dehiscence. And what that means is the actual incision is going to pop open. Please listen to your patients. When they use, especially pop, I feel like I'm going to pop, listen to them because they're probably right. And usually what will happen when you assess that, they say that, then you will see some redness and you will see tenderness and you will see pain to touch. At that point, you need to contact the physician. Okay? You need to make sure that they come in and assess this because the patient may be getting ready to split wide open. The other problem is evisceration. Evisceration is an emergency. It means that an organ is coming out of their body. Okay? Now, mind you, I think have I told y'all this before about what the Neclex world wants you to do? Sterile saline gauze. Right? What would happen if I was in that situation? I would grab whatever I could and scream my fat little mouth off. I need some help. Right, get them back in the bed, get their knees up, get them comfortable. Do not run down the hall as your patient's intestines are laying out on the floor. I gotta get a sterile gauze and some sterile saline to put this as your patient. The Netflix world wants you to say that. The bad thing about eviscerations is it happens most of the time when my patients go home. So teaching them about having an organ come out can be very disturbing to them. Okay? So be very tactful with your instructions when it comes to teaching them. You don't use the term an organ coming out of your body. Try to be more, if it's popping open, that kind of stuff. Don't talk to them about that. Okay, oh, I'm going the wrong way. All right, this is one thing I did want to get to. I'm not going to sit here, since y'all's main focus is getting through these dad blasted PowerPoint things. So y'all will have some, when I'm giving y'all everything that y'all can possibly know. And repeat everything y'all. Okay, this is one of the biggest things I had them show me or bring me the other day. Have y'all seen drains? Because this is a big part of carrying. I'm going to pass this around. This is called a hemovac. And my little, it's got a big needle on the end there, so I want y'all to be careful. Put it all together. This, okay, actually I can just take this off because I'm afraid somebody will cut this myself. All right, what happens in surgery is the patients are, especially orthopedic or abdominal, they can have a drain put in their abdominal cavity or wherever it is, and the purpose of it is to drain the fluid, excess blood, whatever, off of the operation site. Okay? You'll see this very commonly with orthopedic patients, especially the hemovacs. So the way they work is it's like an accordion.
Don't do that.
Don't do that. This was an old antique one. She came, I asked the surgery nurse, I was like, did you have any more of these? And she was like, no, I don't have any more. And then she came in and she said, this one's antique, you can have it. So, all right, see, it looks like an accordion. All right, so this is actually in my patient. And when they insert it, they hold it down like this. And when they push it down there, will you push that? I don't know what it'll do because it don't have the suction on it. Yeah, just close it. So I'm holding it real tight. All right. Okay, this is not going to do because it's not. This will be, I can't clamp it. Yeah, if I clamp it, it's still going to, yeah. Oh, I did. There you go. Okay, see how it come over just a little bit? Now, as the drainage comes into this little contraption, it'll start rising like this. And then when it starts getting really, really full, I'm going to have to empty it. Okay? And I'm going to count it in my output as well. So all I need to do is pop this. Pop it, you know, with the blood everywhere. I need to empty it, count it, okay? But I've got to make sure when I do this that I'm maintaining the suction. So when I emptied it, I'm going to squeeze it back down and then put that there so it'll keep it. The same thing with the Jackson Pratt. Have you ever seen a Jackson Pratt? It looks like a bomb or a grenade. Yeah. So it is the same way, but you've got to remember when you're opening these up, emptying them then, you've got to squeeze it back. And with the ball, with the Jackson Pratt, you've got to squeeze it. So it actually looks like a bomb that's squeezed like this. Because if you don't do that, it's not going to pull the fluid out. The extra fluid and stuff. Do you want me to pass this around? I mean, y'all can come look at it if you want to or play with it.
You gotta take it out, make sure you release the valve so you can take it out.
Right. Okay, so, where's this little thing? What are you doing? All right, there's pictures of Jackson Pratt and everything in there. All right, pain, I'm not talking about pain. Emotional, labs, we've talked about those. All right, do y'all need me to read anything on here?
Every word.
You're good.
Thank you, baby.
Yeah, anything that's on the screen.
Yes, anything on the test.
What? There's dehiscin. Narcan, you know about Narcan?
They read it all.
All right, are y'all glad I made it through? All right, what kind of questions?